Good evening. It's now 19:05 and I would like to start the meeting of the Health and Wellbeing Overview and Scrutiny Committee. I'd like to remind everyone present that this meeting is being recorded, and also can you ensure that all mobiles are on silent. I will be chairing the meeting tonight as Councillor Ralph has COVID, and I'm sure we will all wish him a speedy recovery. The way I intend to run the meeting tonight is as follows. The presentation of each item of the agenda will be completed without interruption. I will then ask any questions I have and then ask each councillor individually if they have any questions. When each councillor has had an opportunity to speak, I will then throw the subject open to any further questions that haven't been asked. So, item 1, apologies for absence. As I've already mentioned, we've received apologies from Councillor Ralph, Kim James, Neil Woodbridge and from Ian Wake this evening. Item 2. I move that the minutes of the Health and Wellbeing Overview and Scrutiny Committee held on the 3rd of March 2022 be approved as a correct record. Does any member have any comments on the minutes? No? Approved? Thank you. Item 3, urgent items of business. I've not agreed to any items of urgent business. Does anyone wish to raise any points on briefing notes? No? Declarations of interest. Does anybody wish to declare a declaration of interest? No. Item 5, sorry. Items raised by Health Watch. As Kim has sent her apologies, I will now move on to item 6. Item 6 is Integrated Medical Centre updates. I would like to introduce Timothy Hemmings to the committee and ask that any update be provided, please.
Hello, I hope you can all hear me. My name is Tiffany Hemming and I have been working on the integrated medical centres for a couple of months to try and get the programme up and running and back into things happening in a timely manner. Let me share you my screen and then we can get going. Hopefully you can see. No, that's the wrong screen now, isn't it? Joyful. Let me reshare the new screen. This one. There we go. Can you see that? Can you hear me?
Yeah, we can hear you, Tiffany. Thank you. We also have paper copies here, so we can follow through on that.
Excellent. Okay, so let me start with Corringham. So Corringham Integrated Medical Centre, there is just over 1,200 square metres of space available in the building for health and social care, plus community use, and we're encouraging community groups to come forward for using that space, particularly at weekends and out of hours. That's a really big part of the plan for the IMCs. There's a second site at Corringham Health Centre that's now going to be available for delivery of services. So we will have more of a campus approach across the two sites, which I think is really exciting. And I'll come on to why that has come about on my next slide. So the site is due to open probably late July 2022. It's just going through its final commissioning period in terms of getting the electric meters sorted out and then running through everything that runs in the building to make sure it all works before the building is formally handed over from the builder to NELFT and then is available for use. And we plan on moving services in over the next couple of months, sort of July and August into September, to try and make sure that we can get as much in there as quickly as we can. Community services are moving from other sites across Thurrock. We also have acute and outpatient services moving in there. Some of those are new. So the AAA screening, which is abdominal aortic aneurysms, which is essentially where a blood vessel becomes very unstable and is at risk of bursting in your abdomen. There's a high risk of that relative to the general population across Thurrock, so we're putting that into each of the IMCs actually as a new service to try and pick that up before it becomes a problem. There'll also be the ability to take blood samples in every site, including Corringham, which again is quite exciting, and also ultrasound. So the primary care services were originally going to be provided by 2 branch practices that are based in Corringham Health Centre, and we were going to knock down Corringham Health Centre and effectively remove it from the ability to provide any services at all. So we've now decided that we will keep Corringham Health Centre. So instead of just moving the GPs from one site to another, they will now stay on that site, and we will have an additional 5 rooms for GPs to provide services inside the Corringham Integrated Medical Centre. So that will be provided by something that's called a GP fellowship scheme and some primary care network appointments, and I'll explain that more in some detail shortly. So I understand that there's concern about car parking around this site. We do have a policy for car parking, and we've prioritised it for patients, and staff are encouraged to use alternate means of transport where they can, or car share, or to park in local car parks. In terms of the primary care provision, what we're going to do is to work towards integrating, why it's called integrating medical centres, the GP care with the community services and the acute outpatient services. So what do I mean by this? If, for example, you've got diabetes and you normally go to your GP and you maybe see the community diabetes nurse, and maybe you also go for outpatient appointments, all in different places, in the future, as we develop our service more fully, you will be able to have a single appointment, and all of those clinicians will have talked to each other in what we call a multidisciplinary team meeting, so that they understand that patient and they can provide better care to that patient in a single setting. So they only have to go to one place to receive, hopefully, all of their care. Now, I mentioned on the previous slide about a GP fellowship scheme. What is that? I know that's a very strange thing to be called. Well, the plan is to recruit an additional 12 newly qualified GPs, so they're completely fully qualified. They can do all of the normal GP work, and we're going to recruit them to be based in the Corringham IMC from September of this year. So their training programme to become qualified GPs finishes in August, and we plan to start employing them in September. So these GPs will spend about half their time providing extra GP appointments across the whole of Thurrock on behalf of local GP practices. The way that will work is we're working very closely with the GP practices now to work out which GP practices want one of these GPs, because they have to pay for them as a small business for the half of the time that they're with them, and where they will then do their work. That is expected to be across all 4 PCNs. So all 4 PCNs in Thurrock will benefit from these 12 GPs. We've already got significant interest. So, for example, in the Corringham Stamford La Hope PCN, we have at least one practice that wants 2 of them. Whether we can do that or not comes down to how many practices want at least one. So these GPs will do half their time doing what you understand a GP to do. The other half of their time, they will carry on studying essentially in an area of special interest. So that might be dermatology or gynecology, cardiology, or any of these things on the slide. And they'll work even more subjects, and they will work really closely with MSCFT to develop their skill. They'll become part of that clinical team. That's very important. And they will then be able to provide clinics at Corringham IMC initially, and potentially elsewhere across Thurrock as they get going in these areas of specialism. Now, when they can provide their first clinic kind of depends on the specialty. But what they can do even before that period is they can provide, for example, I talked about diabetes earlier. If one of them is interested in diabetes, then potentially they could be doing the normal work with diabetic patients across the PCN in an area within their own PCN, potentially also in the Corringham AMC for the Corringham Stamford Le Hope PCN. So they would be able to see all the diabetes patients potentially from that PCN and become more skilled just because they're seeing all the patients, they get to know them very well, they work very closely with the diabetes team at MSCFT, and they can provide a better standard of service than potentially is already being received, and we can hopefully control the diabetes better in future and reduce the other potential side effects, problems that you get with diabetes, for example. So there will be other services provided from the Corringham AMC as space allows. We've already identified that they will have a full-time obesity clinic in there run by the Stamford Le Hope Corringham PCM. As I've just said, they're planning to have chronic disease clinics such as diabetes, maybe respiratory disease, maybe cardiovascular disease. These will all come. And that also, I think you're aware of the extended hours service that is coming in October 2022. The plan is to run that from the Corringham IMC so that anybody can come and access those services if they need out of our services. And there'll be opportunities to book appointments with other healthcare services on the site, including, for example, social prescribing. Now, how you book your appointment is you contact your local GP and they book an appointment. They have electronic booking themselves, so they can see what appointments are available, what have been booked. So different surgeries can be booking into the same block of appointments, essentially. There's no problem with that at all. So I thought you'd like to see some photographs, which I haven't included in the presentation that I sent. So this is an aerial view of the Corringham IMC. It's a very smart building with some car parking there, and you can see the entrance by the zebra crossing just at the bottom right of that picture. This is on the roadside, looking very smart. This is the entrance. And this is an example of one of the treatment rooms. The Purfleet IMC is a little bigger. It's about almost 50% bigger. And that's again available for the same use. We've submitted an outlined business case to NHSEI in March of this year, and that's expected back this month or next month. We have received some follow-up questions, and those are due back by the end of this week. We're on track to submit those answers as we speak. They will deliver community, acute and outpatient services as well as primary care. And the primary care services there will be provided by a resident GP practice alongside some PCN appointments. So the full business case drafting will start later this summer, and the schedule for opening is 24-25. If we then move on to Tilbury, very similar but much larger space, so just over 3,000 square metres currently. That is being worked on as we speak to work out what the exact number of square metres is going to be. It's quite an expensive space at just over £7,000 per square metre. The outline business case is in draft. It's waiting for some final details from Pick Everard, who are the council's design team, around the internal building layout and, as I said, the total space that we will then have in the building. We are including in the outline business case the answer to all the questions that NHSEI asked about Purfleet, because it makes sense to do so, and hoping that that will speed up when the Tilbury document goes to NHSEI. Hopefully it will speed it going through there. So the outline business case is due to go to the programme board the 23rd of June. If it doesn't quite make it, we'll have an extraordinary meeting of the programme board to make sure that we can still submit this document for the next iteration that goes to NHSEI, which is in early to mid-July. The current planned building is a bit too expensive within our healthcare resources, but we will include in our bid, it says additional capital funds. Actually, that's not true. It's but the ability to spend additional resource funding that's the issue. So community, acute and outpatient services are all planned in there. It's got, in theory, about the same amount of outpatient services planned as at Purfleet. And again, it's got a resident GP practice and PCN appointments in there. We'll commence drafting the full business case alongside Purfleet. So we'll start doing some work at risk, if you like, before we get the answer back from NHSEI. So again, we can speed this through to schedule the opening for 24-25. So that's where we are with Tilbury at present. And Gray's IMC is a very different beast. It's still under development in terms of the key user requirements. We have a finance gateway to agree those key user requirements, how much space they need and where the funding is going to come from. And that's set for about 2 weeks from now. And a workshop was held to determine the co-location or nearby location for primary care with the Stifford Clays practice, but we don't yet know what those results are. We're waiting for ARCUS to report back to us on that. So we're expecting design work to commence next month and then the outline business case to be submitted this autumn. Again, there'll be community, acute and outpatient services planned alongside primary care. There will be a much, much larger acute and outpatient services run from this site than any of the other 3 sites. And then primary care, as I just said, could be located on site, but might remain at Stifford Clays in a campus style arrangement with the ability to run appointments from the IMC site as well as the Stifford Clays site. There is also, concurrent to this, a short form business case being submitted for the Community Diagnostic Centre, due to be submitted in September of this year, and the exact location of that has yet to be confirmed, but it's related to the closure of Orsett Hospital because some of those diagnostic services will move into the Community Diagnostic Centre, essentially our centre of excellence for diagnostics outside of the hospitals. And again, this is scheduled for opening in 24-25 alongside the closure of Orsett Hospital. So that's where we are just now. I'd be delighted to take the questions. I'm sure you will have many questions.
Thank you, Tiffany. I did have some questions prepared, but it appears that you've answered most of them in your presentation. Just one thing, I know you spoke about Tilbury IMC. The deadline was originally the 31st of March, and that was extended. It now appears, though, that the redesign, from what you're saying, is not cost saving as initially stated. So, but can you just clarify in your statement you made that the additional costs are now being looked at from another source?
So the redesign came back, and although they initially thought it would make some savings, they came back and it saved relatively little. So now we're just making sure that the design actually works, and at the moment it doesn't. So in a healthcare scenario, you tend to need some rooms adjacent to each other, and that hasn't happened in the way it's been designed. So that's being put together now to make sure that we put forward a plan that works in terms of patient flow. So, for example, if you've got a store cupboard for a treatment room, that store cupboard is beside the treatment room, not at the far end of the building, which is how it was in the design that came back. And there were a few other things as well. So that's all being sorted now. That will then determine how much space we have in the building, which is why I'm not quite sure exactly how much it is. It won't change by a huge amount, though, no more than about 200 square metres down. That will then determine the overall predicted cost for the building. Now, the capital cost is being borne by the council. The cost for the NHS will be at the district valuation cost, and that will determine, I guess, the number of years that the lease would need to be for to make sure that it pays back all of the cost to the council for that initial investment for the building. The question that is coming up is whether that district valuation cost will be affordable or not. It was felt that if we could reduce the overall cost of the building, that the district valuation cost would likely come in at something that we could manage with an uplift, if you see what I mean. At the moment, we don't know what the district valuation cost will come in at. We just have to wait for the final design and then put it in and then see what the gap is. The assumption at the moment is that it will be slightly more than we can afford. The question is whether we can persuade NHSEI that we should spend that money anyway. Does that answer your question?
It does to a certain extent. It's just that what's the problem if we can't afford it? What happens then? We were spent all this money and what's that? So there must be a fallback position if the NHS England aren't going to give us the additional funding we want, or we wasted all this time.
There isn't a fallback position currently, which is why we're sending this in. We're also sending in a very strong linkage to the town's regeneration scheme, for example, which we believe gives it significant additional benefits and might be able to persuade them to allow us to move forward. But we just have to wait for them to come back.
All right, thank you. And just one more thing. I mean, obviously, some of the items you talked about that are going to be moving into the Corringham Centre are going to be moving out of Alsip Hospital, for instance, and possibly in some cases Basildon, I'm not sure. How many of those services will be available from day one of it opening?
We're having what's called a soft launch for the building, which means we'll move services in gradually over a few weeks. So within the space of about a month, 6 weeks, we expect to have pretty much everything operating out of there, assuming that everything goes according to plan as we move it all in and start operating. Okay,
thank you. I was concerned it could be a few months. I'm happy to accept sort of like 4 or 6 weeks, but not 4 to 6 months. Okay, no, fine.
We need to be using the building because we're paying for it. So as soon as we can, we'll be using it.
Yeah, no, fine. Okay, that's all the questions I've got. I'll now go, as I said earlier, I'll go around the councillors and ask if they've got any questions. What I'll do is actually do it on the way it's printed out on the sheet. It'll be easier. So, Councillor Fish, do you have any questions?
The only question really that you haven't covered yourself, because I was concerned about the funding myself, is with Corringham IMC, it mentions the second site at Corringham Health Centre. I've used that fairly recently and I had problems there with parking. There wasn't any parking available adjacent to the building, which meant I had to cross the road and because I'm a wheelchair user, that actually made it quite dangerous trying to cross that road in a wheelchair. So trying to use that site independently with the way the parking is at the moment for me was quite difficult. So what arrangements are there going to be for the parking? Is it going to be similar to the main site whereby the staff use public transport or car share?
So at the moment we haven't done anything around the car parking at that site. At the moment it will continue to be providing services just for the 2 GP surgeries that are on site. So there will actually be a decrease in traffic in the short term, I guess, going onto that site, so it should be easier to park as NELF move out of that building and into Corringham IMC and other services as well. As we develop a strategy for that building, that will include a travel plan and it will include the parking as well. We've only recently made the decision that we are retaining that building and not knocking it down, so we haven't yet gotten very far with that strategy. We were only talking this morning actually about kicking off that piece of work to make sure that we understand what the health need is for that building, what we plan on putting into it, and therefore how we're going to run it and what we're going to do with the space inside that's not used for the current 2 GP practices. So it would be all part of that wider work.
Okay, I'm encouraged by what you say about having some kind of strategic approach to the parking, so thank you.
Councillor Polly.
Thank you, Chair. I have a number, I'm afraid. So with the Corringham IMCs, we mentioned the 12 potential fellowship GPs and extended appointment times. Will this work in the same way as the hubs do at the moment, or will 111 have access to the out of hours appointments there, or will it only be through their own GPs that they can make extra appointments? Because GPs will still keep to their regular hours at the moment. And again, one of our biggest problems throughout the borough, you know, especially as we move to Chadwell and Tilbury, which is giving me, I'll get to that in a minute, is the absolute lack or perception of lack of primary care appointments that are available to residents. I think every councillor on this table gets daily communications from their residents about not being able to access primary care. The Purfleet IMC, again, these have been in the talking shops for so long. I'm still really concerned that we're at a stage where we're still talking about outline business cases, and we're still drafting reports and making financial justifications for something like the Tilbury IMC. Those issues give me a bit of a concern. The Grays IMC, I think, has been a concern for everybody on this committee because of the initial understanding it was going to be a new building, then the relocation to Long Lane, and now we're talking about the Community Diagnostic Centre, which, as you quite rightly say, I mean, the cancer unit at Allsit is doing fabulous work there. And just finally, Tiffany, you said that Allsit is due to close in 2024. This committee repeatedly puts the same question. There is to be no closure of Allsit until all of these centres are up and running and all the services that are at Allsit are available to the Thurrock residents. That's been written in stone from the start. We can't be talking about closing Allsit until everything else is up and running. I'm sorry. Thank you.
Okay, no problem. So Allsit Hospital is due to close as all 4 are opened, if that makes sense. So the plan is that it will relocate its services from where they currently are into the IMCs, and only then will it close. That is the plan. So I think I can reassure you on that in terms of the current planning for the opening of the 4 and the movement of the services. We've identified which services are going to which sites, and therefore what the space requirements are on each site. So it's very, very tightly linked. In terms of accessing out of hours appointments, which was your first question, the extended hours will be open to 111 to book, as they can also see GP appointments, so they can book GP and the extended hours appointments as well. And you can also book via your own GP for the same band of appointments. They're all linked electronically. It's very easy for the receptionist at any of the PCM practices to book appointments at their local extended hours appointments. In terms of accessing GP appointments, Mid and South Essex as a system have identified that Thurrock is under-doctored in terms of GPs, and it's prioritising Thurrock as a consequence for the GP fellowship scheme. So it's starting in Thurrock, not anywhere else, just in Thurrock. Those 12 GPs, for the half time that they are in doing general jobbing GP practice, sort of thing you expect them to be doing as fully qualified GPs, they will provide a minimum of 500 appointments a week across the whole of Thurrock. So that is within the 12 linked practices, and some of those appointments may well be run out of the Corringham IMC for the local PCN. So that's a significant addition of appointments. What I can't tell you is where they'll be located at the moment, because I haven't yet got small business holder GPs to sign on the dotted line to say they'll take a GP. Once we have those data, we'll be able to understand where those additional appointments will be available. So that's, I think that's a really good news story for Thurrock, and something I'm really excited about, making sure that we can bring that in. And I'm just as excited actually about the GP with special interest part of it, because that means that we can really integrate the service and enable people that currently go to hospital to be managed for things that a normal GP doesn't deal with, to be managed at the IMC. So starting with Corringham, and then as the others open, we'll be able to put services in all of the IMCs to have GPs managing skin conditions and diabetes, cardiology, respiratory, gynecology, lots of different things that they can be managing that ordinarily you might have gone to hospital to have an outpatient appointment for. So I think, again, that's a very exciting step forward for the whole of Thurrock.
Thank you. Councillor Apothecary.
Thank you, Chair. Thank you, Tiffany. I'm going to go back to Councillor Polly's, one of Councillor Polly's questions, because I'm not entirely sure your answer answered quite what she asked. So, yes, we can see that the timeline on paper is that ORSIT is scheduled to close 24-25, and we can see that on paper these sites are due to open in 24-25. We're in June 2022. I'm looking at Grays, which we're only doing things like outline business cases, etc., in autumn 2022, which could be as late as November 2022. So we're essentially talking about 2023 by that point. This process so far has not inspired me with confidence that this process can move quickly enough to have doors open on 3 IMC sites by 2024-25. For me, what I need is a reassurance that, firstly, what happens when, or if you like, if these sites aren't delivered, and adding to that, the fact that the Community Diagnostic Centre, we don't even know where we're going to put it, and Grays is not an area that has lots of space. It's a highly built up area. There's not, bags of sort of sites. What is the guarantee? What happens if we don't get these sites over the line by the scheduled closure date for ORSIT? Does ORSIT remain open, which is what, as Councillor Polly said, we have been exceptionally clear as local councillors must happen. It must stay open until every single service currently provided at ORSIT is provided somewhere in Thurrock? Or is it just ORSIT closes and there's a gap that has to be bridged, which would be the worst case scenario? If it is the case that ORSIT remains open, has that been budgeted for? And if it hasn't, where does that then additional spend come from?
Okay, so I absolutely get your concern, having been parachuted in to have a look at this programme from the beginning of April of this year. And I'm now moving sideways into one of the executive director roles at the system, but I will still be involved in this. I am bringing in 3 people who will be dedicated to work on this programme as a permanent programme management office, to make sure that we are doing everything in a timely manner, that nothing gets dropped, that everything happens when it should, and importantly that we have a very good record of everything that's happened. Can't say that's true of what I've managed to find in the past. I'm also bringing in a part-time leader person, somebody to lead the programme, to make sure that we've got, again, a dedicated individual to make sure that things are pushed forward and do actually happen when they're supposed to happen. I think that will make a very big difference to actually seeing some activity and things being delivered on the time schedule that we have set. In terms of Orsett Hospital, it has thus far been essentially being talked about by MSCFT, sort of linked into the programme of for project, sort of not. I'm shaking up the governance significantly and explicitly bringing the closure of Orsett Hospital workstream into the programme so that it is completely linked to the opening of the 4 sites, to make sure that we have appropriate accommodation across Thurrock, as you just stated, for all of the services in Orsett Hospital before it closes. In terms of budgeting, as Orsett Hospital draws down into the sites, there will be less and less on site. We're already paying for a little over 5,000 square metres of space that we are not using. We're paying for void space already on that site. So we'll carry on paying for void space until it empties, and that is in the budget. What won't be in the budget is that continuing to stay open. However, that will be countered by the additional costs that we would be spending on other buildings as we move into them, because they're currently more expensive than what we are paying for today on a square metre basis. Whether that balances out, I couldn't tell you. But as I said at the beginning, I am working particularly hard to make sure that we have a much tighter process for things that are supposed to happen on time, and make sure that we can deliver these buildings when they are supposed to be delivered.
Could I come back, Chair, just to clarify something that Tiffany said there that I think may have been slightly misleading?
Yeah, I'll let you come back, Councillor Potter.
Thank you.
I'm just aware of the time, so...
Thank you, Chair. So I'm going to take that as there isn't a commitment to keep Orsett Hospital open beyond 2025, essentially. One of the things you said...
There's no specific closure date at the moment. It is explicitly linked to the other sites.
So it doesn't close unless the sites are up and running?
There is no plan to close it before the services have moved out.
Okay.
So no.
Okay, that's great, thank you. I just wanted to clarify something that you said, because I think I read it one way and I'm not sure it was correct. You said something about square footage in terms of paying for buildings. And
yes.
You seem to suggest that the new centres are going to cost you more to run per square foot than the current provision at Orsett does. Is that what you meant?
I believe that to be the case, but I can come back and confirm each of the sites. So Corringham IMC is more expensive on a square meterage basis than the buildings it has replaced, but that's because it is in better condition. It's a nicer building. It's a more modern building.
Thank you. Councillor Salmons.
No, I think all the points that I wanted to raise, Councillor Podgary's raised. I was just rather concerned that Orsett wouldn't be closing until everything is up, running, working.
Thank you. And Councillor Snell.
Yeah, thank you, Chair. I think actually Councillors Pothecary and Polly covered most of what I was originally going to say. One thing I am a little bit disappointed at is that I was in on the very start of these IMCs, and back then we were talking about having GPs actually physically based as the GP surgeries that we know in the IMCs. Am I right in thinking that is not actually the case anymore? So you won't visit a GP like you would do at the moment at the IMC, you would see your GP elsewhere, and they might feasibly refer you to the IMC beyond that. Is that how it works?
So yes and no. So it depends on exactly how things go at Corringham. In terms of the other three, the plan is still to put GP services in there with a GP that provides to a proportion of the population served by that IMC. In all 4 sites, there will be some primary care network services, so services provided by a group of practices that come together to deliver shared services, and that will be at the IMC building. So then that's open to the entire population across that PCN where the IMC serves. So your GP may well be offering appointments at the IMC building. The way that you book those is through your GP. It's not referring to anyone, it's through your GP. When it comes to chronic diseases, again, they're not referring. What they're doing is they've got a GP that specialises in that particular area, who works at the IMC for a certain number of clinics per week, and they will provide enhanced services, if you like, for that GP practice. So it may not be your standard GP for everything else you see, but for your condition or conditions, they will become your specialist GP that you will see specifically for that. That will give you a higher level of service than you currently receive, because that person will be seeing pretty much everyone in the PCN with that particular condition, and therefore will become very, very good at managing that condition effectively and helping people to get the best quality of life they can.
Yeah, okay, thank you very much.
Right, thank you, Tiffany, for your presentation and the questions, responses that you've given. Would it be okay if anybody from the committee had any other questions, if they got them to you, say within the next couple of days, would you be happy to respond to them?
Absolutely.
Right, thanks very much. So if anybody that hasn't had a chance or something crops up, then Tiffany's quite prepared to accept it. So thanks very much, Tiffany, for your presentation. If you wish to leave the meeting, by all means do.
Thank you.
Right, moving on to item 7, integrated equipment service reprocurement. And can I ask Catherine Wilson to present the item, please?
Thank you, Chair. Sorry, I've not spoken. Thank you very much. I've brought Ian, my colleague, with me because this work sits within his portfolio in the commissioning team. So if there are any questions I can't answer, I'm sure that Ian will be able to. This report, as you said, is regarding the proposal to reprocure our integrated equipment service. And as members will be aware, this contract covers a range of equipment from grab rails to raised toilet seats, walking frames, special beds and hoists. So just to give you a flavour of what is provided. As a local authority, we have a statutory duty to provide equipment that meets assessed need, to support people to be as independent as possible in their own communities. Currently, we are part of the Greater Essex Commissioning Partnership, which consists of Essex County Council and ourselves, 4 CCG footprints, EPUT, East Suffolk and North Essex NHS Trust and Mid-Essex Hospital Trust. We contribute £662,000 a year to this contract, providing roughly 1,900 pieces of equipment at any one time to the residents of Thurrock. The financial contribution that we make as a local authority is around 5% of the total value of the contract and gives us supply and delivery of equipment, supporting independence, as I mentioned, together with, very importantly, supporting the discharge pathway from hospital. We have explored other options as to what we might do to commission this service, maybe collaborating with another local authority, a Thurrock-only procurement, or an in-house service. However, at this time, those other options do not give such good value for money. We would have to have additional setup costs, we would have to employ our own staff, purchase equipment, transport for delivery. So, we felt that the recommendation should be that we move forward with the collaborative. The market, as we know, across social care is very fragile, and equipment provision is no exception. So we feel that the commissioning collaborative gives us the best option for getting the best value for money for our contract and a really positive and good service for our residents in Thurrock. The current contract ends on the 23rd of March 2023, and so the re-procurement will start once due process for all organisations has been followed and the proposal has been agreed. I think that lays out the case, Chair. If there are any questions, we'd be happy to answer.
Thank you, Catherine. I just have one question. Although at present the report explains the limited options with regards to the suppliers, is the department going to actively look for more cost-effective options over the next 3 years of the contract prior to extending it, rather than leaving it to the last minute before we look again?
So yes, I think what we will do is be part of that collaborative, and the market is extraordinarily limited. There are only 3 or 4 providers that would be able to provide a contract of this magnitude, really. However, I think that given all the things you are going to hear about shortly with regard to the case to change, really thinking about how we can provide much more local place-based responses, that will be something that we will do over the next 3 years, actually look at can we do this in a different way.
Sorry, thank you. That answers my question. What I'm going to do now to give councillors a chance, I'm going to now go backwards through the list of councillors to give them a so. Councillor Snell, do you have any questions?
Yeah, thank you, Chair. Not really a question. It's just, I think I've been looked at this in previous years, and it looks like not much has changed in terms of suppliers. It's very, very limited. So I would agree that, yeah, there's not really a lot of choice. I mean, I think the most important thing is stability of supply for us at the moment. I mean, purchasing power, yes. Value for money, yes, we get all that. But I think right now we need stability. But I do take the Chair's point that going forward, obviously looking at the micro businesses, perhaps whichever way we can work it in future is probably a way to go. But for right now, I think it's the only choice we've got. Thank you.
Thank you, Councillor.
Tony. Thank you.
Is that better? Yeah, okay. Trust me, get a dummy mic. And I mean, Essex sort of got the jump on this years ago because they set up this massive equipment store. They've got the purchasing power to buy it in bulk, and therefore they are massively competitive. My own view would be I'd love to see an alternative, and I think the future probably does lie in a much more commercial interest in this stuff, and ultimately retail, or certainly now online. I mean, you can buy virtually anything from Amazon, for example. But you need to make the link between the assessment that triggers the need and how you purchase that. that's why there was this idea behind prescriptions. But it's a remarkably difficult thing to break into. But like you, we will continue to explore alternatives, and if there are reasonable alternatives that are affordable, then we'll certainly look at those in the future.
Thank you, Les. Councillor Salmons.
No, I think you've explained that.
Miss Councillor Fish.
No, we're going back.
No, going backwards.
I was going backwards.
Oh, sorry. I'm last this time. Oh, you were last this time. I do apologise.
No, I appreciate that there are some markets that are very limited in the supply chain, and therefore it probably is better to stay where you're at, because sometimes moving to somebody else can prove more expensive in the long run. So it's probably better to stay with what you've got whilst you're looking at alternatives. It's not something you can just make a quick jump into, is it?
Thank you, Councillor Pothecary.
Thank you, Chair. Thank you, Catherine. Thank you, Ian, for the report. I have to say, I mean, it does seem to make sense that we stick with the Essex purchasing sort of consortium, as it were. It seems to make a lot of sense. I was a bit curious, though, about why there hadn't been any consultation with users about whether they were happy with the service that consortium was provided. Under consultation, it just says NA. I'd suggest it's not. It's quite relevant. I mean, do we know how happy residents are with the service? Do we know how the service is currently performing?
In terms of service performance, it's performing very, very well. It's been extremely consistent during COVID, and it's actually facilitated hospital discharge. A lot of what's driving the decision, especially via Essex, who's obviously the main contributor towards the contract, is financial pressures. They're looking to make savings on the contract, but also to improve service delivery, because they've had trouble with hospital discharge there. So the model of delivery of equipment is going to move from 2-tier to 1-tier, so it will be basically trying to respond more quickly to the need to get people out of hospital, so it'll be 24-hour delivery.
And in terms of resident satisfaction?
In terms of resident satisfaction, anecdotally from our side and from KPI indicators and complaints, the performance is very good. Alongside the OT assessment as well, it runs concurrently. Performance very, very well.
That would have been really useful detail to have in the report. Yeah, but thank you.
Thank you. Councillor Polly. Oh, sorry.
No, Paula, you're absolutely right. Thank you. I noticed you've just mentioned the timely hospital discharge, which is noted in the report. And during National Social Workers Week, I was privileged enough to go and visit our discharge planning team, and wow, what a team! You know, the work that they'd done and the work that they'd helped the actual hospitals with. I don't think we could have asked. I mean, they were right through COVID. They were on the wards. They were frontline workers, 100%. Got total respect for them, and that, you know, they were going in. If the nurses didn't have time to do the assessments, they were going and doing the assessments. I mean, we really, I've got some really marvellous people working for us in our team. So, but all of that work, and then you can't send the person home because the commode's not there. You know, how despondent must that make you? You know, so if we are looking at better, you know, hospital works 24 hours, social work works 24 hours. You know, if the ambulance service works 24 hours, like in getting patient transport home. I mean, I know sometimes that's been challenging with families, like having people sent home 3-4 o'clock in the morning. But and again, that I'm sure other councillors on this committee have had that. You know, mum's been sent home 3 o'clock in the morning and there was nothing there for her. There wasn't even a pint of milk in the fridge. So, I mean, if we're going to line our ducks up a little bit better, that can only be applauded and welcomed for better. The only note that I will mention is that on 2.4 it says that where possible to do so, items are collected, cleaned and reused. I think we've all been to the houses where there's 3 commodes, 2 upstairs, 1 downstairs. Family are begging you to take them away. There's walking aids that have become actual trip hazards because as that person's mobility has changed or decreased, a new aid has been provided, which is great, but the old one is still sitting there in the room. So I think there is a bit of work to do on that as well. And I know with the COVID, the last 2 years, it's not been the normal situations, but I think pre-COVID, we're all aware of those situations. But other than that, as with Councillor Pothcare, welcome the report and things. Thank you.
Thank you, Councillor. And Councillor Fish.
Thank you, Chair. When I read the report, I noticed there was a reference to fragility of the market, and so I was quite sort of intrigued by what that meant, but I think we've covered it more or less really by talking about the limited number of suppliers, that kind of thing. In terms of feedback as a service user, because I use the service myself, I'd say it is good. If you need an item of equipment, it arrives fairly quickly. Councillor Polly's point about not taking the equipment away, I think, is my experience as well. I've got at least 2 glideabouts at home, one which is completely useless. I'll never use it again. It hasn't been taken away. The other thing I'd say is if you need an item of equipment which is more bespoke, that's quite difficult because I've been waiting for 3 months now for a bespoke item of equipment, and I was told, because I couldn't use the one that they originally supplied, I was told, oh no, that means we'll have to go outside of our usual sort of range of services that we provide to come up with something more bespoke, and that's the last I heard of it several months ago. So it's sort of good and bad, really. But I think it would have been, I agree with Councillor Pothcare's point that a user survey would have been really important part of it.
Thank you.
Can I just respond to that? Councillor Fish, whatever that is, could you drop us a line and let us know? Probably to Gavin Beard, I would guess, but if you send it through me, because it shouldn't take that long if it's off catalogue, unless it's something highly, highly specialised, and we shouldn't be accepting that level of delay. So if you can just send it to me, and I'll make sure it gets to the right person, and we'll chase it for you.
Right, thank you. We have 2 recommendations. I think recommendation 1 we've already covered, which is the committee to review and comment on the content of the report, and recommendation 2 for the Health and Wellbeing Over and Scrutiny Committee to support a proposed recommendation to Cabinet that the procurement of community equipment should move forward under the current collaborative arrangements. All agreed?
Agreed.
Thank you. Oh yeah. If Ian, because Ian's myself. If Ian and Kathleen wish to go, then you can please do so. Moving on to agenda item 8, which is the Health and Wellbeing Over and Scrutiny Committee Adult Integrated Care Strategy. It's being presented by Kerry.
Thank you, Chair, and I'm going to attempt to share the presentation so people can see that. Pardon? Oh, yeah, well, bear with me. Right, hopefully, yeah, that's up there, so let me just put that on. Right, okay. Right, okay, so I think we're there with the presentation. So the purpose of the presentation tonight is to obviously present the new integrated care strategy to the committee, and that's called The Case for Further Change, and that's for Better Care Together Thurrock. And Better Care Together Thurrock is the name of our integrated transformation programme across health, adult social care and the voluntary and community sector. And in terms of the overview, I'll just kind of be going, I know we've got about 10 to 20 minutes for presentation and questions, so I'll give an overview of the strategy, because obviously I know it's very, very lengthy. So I'll try and summarise the key points and obviously leave some time for questions at the end, should you want to kind of go into more detail about what I've said or about elements of the strategy. So I think just to start, really just to take you back to the start of our transformation journey, which started back in 2011 with the Commission inquiry into housing, I think it was housing, health and social care actually, rather than just housing and social care. And from that point onwards, we've had a really strong history of working across the borough with partners to develop an integrated health and care system and to produce better outcomes for Thurrock residents. And that resulted in the first phase, which was building positive futures, which actually looked at how we could start to build resilient communities, the importance of the built environment, and just the importance of actually what was available to people within their community, and moving away from just a very tired service-driven approach, so looking actually at kind of things that were broader than what their condition or their need was, but also what mattered to them in life. So actually that might be remaining connected with the things that they enjoy doing within their communities. And that kind of premise has really been built on really from that point onwards, right up to now, where we've actually got this strategy, which is the case for further change. The reason it's called the Case for Further Change is because there was a Case for Change in 2017, which launched the first phase of our building our Better Care Together Thurrock transformation programme. And now we're kind of launching, having kind of introduced a number of initiatives under that first phase of the programme. We're now building on that and actually launching this second phase, which is a far more integrated strategy across the borough and far more and focused on place and people. So just to kind of take you through where we are again, what we've got is a whole systems approach now. And the reason kind of why it's a whole systems approach is because people don't tend to present themselves with just single issues. People are complex, they have a number of things going on in their lives, and therefore it's very difficult to actually deliver outcomes for that individual through one service or one organisation. In fact, it's nigh on impossible. So delivering good outcomes for people, outcomes that they want, actually requires a whole systems approach, and that's not just around health and care. But that's also other elements, such as it could be kind of housing, it could be community, it could be drugs and alcohol, it could be whatever's going on in that person's life that needs to be looked at in order to actually help to deliver the outcomes that they want to achieve. And these, on the slide, are just examples of the reports that were developed by the now Director of Adult Social Care, Ian Wake, but when he was the Director of Public Health, he looked at how to start changing the system to deliver or shift it towards a far more holistic and preventative approach, which actually intervened at an earlier opportunity as well. So trying to shift the whole system from one that tended to focus on people maybe at a too late a stage or at a stage where they already kind of went to hospital as an admission, to one which was actually starting from a far earlier point, but actually far greater working across a wider range of partners. So in terms of kind of why are we doing this, and I think I've probably already explained it to a certain extent, and this example is based on an individual who had a range of issues going on for him, and actually, as I said, people often don't have single issues or conditions when they come to us. Yet the system's developed over the last 30 odd years to respond just to that, to single issues. You know, you kind of go and you get kind of your needs assessed for adult social care, or you go and see the GP to see if you can get a referral to mental health and see whether you reach the threshold for that. So people often go through a number of different front doors in order to get their needs met, or actually maybe they don't get their needs met at all, or maybe we meet their needs, but we don't deliver good outcomes for people. So we need a different type of approach for health and care and for people that kind of need that support. So actually, rather than a one-size-fits-all singular approach, we need to move to a system that actually can work together around people to give them bespoke solutions. So there needs to be a greater degree of flexibility and a greater degree of people working together. And for this gentleman, Owen, we're calling him, there were a number of different front doors that he ended up having to try and get through to get his situation resolved. And for each one, and for each one, there was probably a threshold for each of those services. There was probably an assessment that was carried out, and there was possibly a referral onwards. And actually, what often ends up happening is we don't deal with the underlying issues, and people end up in A&E. And then we end up trying to backtrack to try and deal with issues that could have been resolved, or at least kind of minimised had we acted differently earlier. So again, I won't go into much detail because I don't want to kind of go over, what I've already said. But actually, again, the system tends to act when, at the top end of the triangle, when people aren't okay. We often wait until they're actually virtually at crisis point, because actually that's when they tend to hit some of our thresholds. But actually, if we want to do the best for people, and actually we want to use the best of our resources and make that resource go as far as possible, we need to act when people are either okay, or actually when they're in that middle bit, to kind of help them get back to being okay, rather than escalating to the I'm not okay and actually suddenly kind of costing an awful lot more, or actually, as say for them, ending in hospital or a residential care home or whatever it might be. So again, what we have at the moment, what our system's turned into locally, is lots and lots of different services delivered by separate teams with different thresholds and different referral criteria. And our job through the strategy is to re-look at this and say, well, actually, we might need drug and alcohol, we might need complex care, but actually, how can they work together to deliver something that actually is integrated rather than actually very, very separate? So we think what we need to do in order to kind of deliver that is to kind of make a number of changes. The light blue tends to be where organisations that deliver services to people are now. So, top down tends to kind of focus on functions and service deliveries. Its ethos tends to be on, us being in control rather than actually having that equal partnership with people. What we need to get to is obviously something which actually is very, very different. So, moving to bespoke solutions, moving to actually empowering people and staff to identify what they want and to co-produce bespoke solutions, rather than us saying, well, this is what you can have, you've got this condition, this is what we'll give you. So there's quite a shift in terms of culture across the system. So it's not just around redesigning services, it's also about changing the fundamental culture that underpins our system. So that's no easy thing, which is why the strategy isn't going to be done or delivered in a short period of time. This is something that's going to be going on for quite some time. And that then feeds into our transformation principles, and this needs to underpin all the activity that goes on to deliver this strategy. So again, I'm not going to read them out because you've got those in front of you, but just picking up on a couple. Absolutely vital is that we actually act to prevent rather than just to react. It's absolutely vital that we build flexibility into the system, so actually we can flex around what people need because they're individuals. So even if one person has a substance misuse and a mental health issue, that could be very different than the person next to them that has exactly the same. So their needs and the outcomes and what they want will be very different. So it's about working out how we actually transform around that set of principles. So it's really reshaping everything we do. So what we'll have, and this is kind of a bit of a plan, it's a bit busy, so I won't, again, go into loads of detail, but what we'll end up with is a number of chapters within the strategy that deliver what I've just spoken about. So we'll be having kind of a different approach to engagement. So rather than actually going out and doing set pieces of engagement and consultation when we want to hear from people, actually what we need to get to is an ongoing way of engaging, so we can actually feed that ongoing engagement into how we develop services and systems. And that's something we're starting to work on in kind of Stamford and Corringham to begin with. We need a different approach to prevention. So, for example, population health management is very much about looking at controlling those things that often, if they're not controlled, end up with people having really poor health outcomes and life outcomes. So, for example, blood pressure, making sure that we identify and control that to prevent strokes and heart attacks. Things like atrial fibrillation, diabetes, and these are all things that can also be done within the community and not just going to see your GP as well. We've got primary care networks now, 4 across Thurrock, and a lot of the strategy tries to actually create an integrated system around those 4 areas where possible. So they really are focused on communities as opposed to a broader area. And what we need to do again is make sure that we focus on developing a really flexible network of professionals who can work with each other when they have a person that presents with a set of issues or conditions or needs. So rather than sending the person to different pathways, we do the work behind the scenes. So for all intents and purposes, the person is, has the solution, which is integrated because the work's being done between professionals in a multidisciplinary way. And that's not just about services, but that's also about what's available within the community as well. So it's looking at things like being connected within the community and doing things that actually makes life a bit more enjoyable. So again, I'm not going to go into all that detail because it is set out in the strategy and the executive summary, but there are 10 chapters in all, and each of them has a separate theme, but they're all interlinked in terms of delivering the shift we want to see. And each of these will be backed up by a separate delivery plan as well. And again, I blame Ian for this. This is Ian's. Some of these slides are Ian's. He does like whizzy slides. But again, the key on the left-hand side is again showing what might happen with an integrated network of services and functions. So it's not to say that everything's going to be provided on a PCN level, but there will be a lot that's provided on that level. And the key on the left shows kind of what that might look like in terms of the colours. So there will be people that will either work to that PCN, or actually they might provide a link worker to work with that PCN. So one way or the other, we will be providing an awful lot of integrated networks across a range of different services and functions. There will be some teams and some functions that continue to sit maybe on a southwest Essex-wide footprint, because they are very, very small or very specialised. Or it might be that actually through the Integrated Medical Centre, they might do a clinic at that Integrated Medical Centre on a particular day of the week or the month. So there'll be a mixture of kind of services and a mixture of provision at different levels, but actually it's how they all link and interrelate that's going to be the important factor, and importantly how they can work around what the person needs. And this will be the last slide I shall talk about, but just in terms of then what the work we've got to do really, we think there are 3 organisational pillars in order to deliver this. One is actually places an organising principle, so the majority of that being done around the PCN footprint. The second one is around making sure that we can adopt a new working culture. So again, professionals working very differently with each other to provide bespoke solutions as opposed to delivering very, very kind of single functions with one-size-fits-all delivery. So that's quite a shift for some of the services and some of how we work. And some of that is about empowering staff to feel free or be free to actually test different ways of working as well, because it's often our staff on the front line working with kind of people who understand actually how things need to change. So we need to kind of free staff up to be able to do more of that and to develop a more of a learning culture. And then the third pillar, which I've already spoken about quite a bit, is about having that coordinated and bespoke care across, again, the range of services. So regardless of what that person's needs are or the outcomes they want to achieve, we can deliver that through that working arrangement. There are some other slides in there that explain the different chapters and the different recommendations, but I know you're short of time, so I don't know whether you want me to stop there so you've got questions, or whether you want me to go into some more detail about the chapters. I'll leave it to you, Chair.
What's the committee's general view? Are we happy to move on to questions, or do we want Kerry to carry on giving some more of the report?
Should we go to questions?
Yeah, I think if it's okay with you. Right. Anyway, thank you, Kerry, for the report. Welcome the report. I think that Thurrock has proven that we understand what works well. As an example, the area coordinator's role, which has been very successful as far as I'm aware. I had some involvement in the early stages. However, as now nearly everything is going to be under one roof, how are we going to ensure that staff are not going to be spread too thinly, thus jeopardising the effectiveness of the service?
Yeah, I mean, staff won't be any different in terms of numbers, but they'll be working in a very different way. So at the moment, I would say there's an extreme amount of what we call failure demand in the system, where people actually have to go through different doors, staff fill out referrals, they each do an assessment, they're dealing with people twice or three times because they haven't got what they've wanted first time. If we can move staff to a position where they're working together and we can reduce some of that bureaucracy and we can reduce some of the number of times that people have to go through all those front doors, we're immediately creating a lot more capacity for staff to actually do value work, which is kind of actually, face-to-face work with people. So on the one hand, there's not going to be additional resource in terms of numbers, but there will be additional resource because we'll be able to free up capacity through reducing some of those things that just get in the way of doing the right thing.
I think, so are we saying as well that the staff that are working together will have the opportunity to be, shall we say, upskilled or learn from one another, so they have a more diverse knowledge of what's going on, rather than possibly specialising as they do sometimes at the moment in one area?
Yeah, exactly that. I mean, we don't want to dilute any of the specialisms because, they're there for a particular reason. But what we want to do is have cross-fertilisation of knowledge. So at the moment with our social work teams, we're trialling one integrated social work team where specialisms are also working with that team so they can share knowledge and actually be better placed to actually discuss cases together. And the same with with the work we're doing around care delivered in the home. Again, we're looking at part of the strategy looks at what we're calling blended roles, which is starting to think about what other skills we can give those workers. So is it about when they see someone that they're kind of working with time and time and they notice that they're kind of a bit off colour or they're not looking at, like they did yesterday, could they kind of could they test for some vital signs, or could they do a blood test, or not a blood test, sorry, a blood pressure reading? Could they do a urine dip test? Could they be trained to change some maybe kind of more simple wound dressings, things like that? So we're looking at all of those things as part of the strategy.
Thank you. I'll now throw it open to questions.
I've got one.
So, yes, you know you was going to come. You knew I was going to go the other way around, didn't you, Councillor Fish? Councillor Fish.
Well, I've got a couple of things to say, really. First of all, I was involved with Building Positive Futures. I was the portfolio holder in those days. And I'm really pleased to see this because I think it builds on the values that we were talking about then, and some of the ideas in here actually we're talking about then as well. I notice there's a lot of emphasis on the word learning in it, and just have a slight concern about how that learning might take place because, like I said, it could become quite bureaucratic. So just if you can just reassure me about how that would happen. And then the other thing was about the. I was going to say about my experience. So if you could tell me about how the learning will be done first, and I can follow on from there.
That's good because I might not remember your second question, so I'll respond to this. Yeah, I think we use learning in the sense of how we're going to empower staff to think about doing things differently. So there's a technique called human learning systems, which we're actually looking at in order to help us, where actually staff are empowered to maybe look at a case where things haven't gone so well. So whether it's, say for example, it's someone that's got a complex set of circumstances, maybe they've got a housing issue, mental health, substance issues, and at the moment they might go through separate doors, and actually they might have different thresholds, and different services might say, well, actually no, you can't come to us until you get that issue sorted. No, you can't come to us until you get that issue sorted. Through learning, what we're doing with that instance, for example, we're getting a number of members of staff who work across those functions together, and actually saying to them, look at that case and look at how you would do it differently. And actually, so there's it's not bureaucratic in the sense of we're not putting lots of paperwork or project management or templates in place. We're asking people to actually be quite solution focused with problems that we know exist in the system. So as cases arise, or as people realise that they're doing things that could be done better, more effectively, or reducing bureaucracy, the learning is just saying to people, feel free to actually look at how you could do that differently. So that might be a case of just a couple of people working together on something which is quite a small issue, or it could be when you actually want to redesign a whole service or a number of services, that you have a slightly bigger, what we're calling experiment. So I think learning is mentioned a lot, and it's mentioned deliberately because we want a learning culture. But in terms of how that's done, it's definitely not designed to be bureaucratic. It's designed to be a vehicle through which we can change what we've got at the moment. I hope that kind of, I mean, we can bring back examples as we deliver this if the committee wants.
Can I add something?
Oh yeah, I think, can Les come in on as well?
Actually, I think it's important to understand as well, Tony, that there is a cultural shift involved in this, and you're right, it goes back to some of the things we learned way back then, and one of the most significant things we learned way back then was by empowering staff and trusting them and protecting them, because staff need to know that they're not going to be thrown under the bus if something goes wrong. Actually, you create a great deal more innovation and creativity, and people find lots of different solutions to what seem to be intractable problems. So human learning systems is an alternative to new public management, which is the system we've lived under now for the past 30 years, which is driven in a very mechanistic way. It says you can define exactly what you need to create in a performance management framework. You can come up with a series of performance indicators. You can then set them up in your contracts or in your relationships with your staff, and you will be able to evaluate and tell how successful you're being. And that will drive efficiency, and it will also drive effectiveness. And actually, the history of the last 30 years has been a complete failure, because we're spending much more money than we've ever spent on this, and outcomes haven't improved in many cases demonstrably. And the reason for that is people are amazingly complex, as Kerry has already suggested. And the system that we're in is very chaotic because it's about humans, and it's about people and their human frailties and their traits and, you know, their different requirements and all of that. So it's virtually impossible to use that mechanistic management framework to drive improvement, because you will never be able to measure the right things in a simplistic way that will tell you whether something's working or not. So human learning systems says, well, one way around this is we should be commissioning for learning and empowerment as part of everything we do. So it's not learning in the sense of getting everyone together every 3 weeks into a training session. It's saying, actually, we're freeing you up to learn on the job, to collaborate, to share experiences with other people, and to grow from that position. Equally for organisations, you know, we're defining the collaboration that exists between organisations and indeed between different parts of an organisation, so like the council, are valuable, and they should be part and parcel of our culture and of everything we do. So it's that sense of allowing learning to be an organic process, and to allow staff to understand that we expect them to be innovative and creative. We expect them to find solutions. In fact, we expect a massive reduction in bureaucracy, because we all know, working for local authorities, there's mountains of bureaucracy that at the end of the day you think, well, does that really make any difference to the citizens? Of course it doesn't.
Thank you, Les. Can we move on a bit?
Yes,
We've
sure,
got what's up? No problems. Another question, Tony, or?
I just wanted to tell you about my experience quickly of what I've had recently is treatment for a leg ulcer and how that's changed. I had the same thing 5 years ago. 5 years ago, you'd go to the leg ulcer clinic, you'd see the tissue viability nurse, and your treatment would all take place in the leg ulcer clinic. They provide you with hosiery, which helps the blood flow. This time, what they've done is the service is now closer to home, because it's provided. You see the tissue viability nurse, and then the treatment they prescribe is done at your local surgery. That's fine. That's all worked well, apart from the hosiery hasn't been available. Nobody seems to understand. The tissue viability nurse doesn't know how to get the hosiery. My surgery doesn't know how to get the hosiery, and without the hosiery, your treatment doesn't really. It takes 5 to 6 months when it should take 6 weeks. So that's an example of how the service has moved closer to home, but it hasn't really done its job, because a key part of it is just not. They haven't learnt how to do that, so the learning has failed there. Yeah.
Exactly, and that's exactly what we're talking about.
Okay, thank you, Tony. I'm sure that will be taken up, that issue. Councillor Polly.
Thank you, Chair. I think one of the things I'm looking at these reports, that we're still very GP-paced. A lot of the services that radiate have to have that first front door, whether we're reducing them for service users or residents. There has to be a trigger. We spoke at length earlier that primary care seems to have shut its front doors at the moment, and a lot of our service users have deteriorated or that because they haven't had their referrals, they haven't had their ongoing treatment. So I also noticed on one of the points raised here was access to primary care, population needs in area. Based on what data? Where are we always going to be out of date? Was it the last census? Was it the, what population? Because we're expanding, we've got a big growth agenda in Thurrock. If we're starting on the back foot because we're not planning our services for, well, not so much the local authority, but obviously the partners within this. We don't always seem to use the same data either. The NHS will use one set of figures, we will use another set of figures. So that gives... It does sound like a Shangri-La. It sounds a little bit too... It's like that lovely big pie crust with layers and layers of flaky pastry. Tap it and it all falls apart because the substance isn't there, perhaps. And I don't mean that in a bad way. I just mean that for that to work, everybody's got to be in that same boat, rowing in the same rhythm, at the same pace. And if we could deliver this, amazing. But I just, because of the partnerships that it involves, and again, I think, I don't want to speak for every councillor around the table, but one of my biggest workloads is housing. Is the housing stock. We've got the condition of the housing stock. When you've got somebody with complex social needs, as we've identified, some people with mental health, with substance you know, inherent, come from generations of families that have it's learnt behaviour, they become a bad neighbour. And then I agree, the LAC teams have been marvellous, but I'm still experiencing, I've got an ASB officer with one family, I've got a TMO with somebody else, I've got an LAC with, I just, like I say, if we could deliver it, we absolutely, but as Les and yourself have said, there's still some learning to be done. So thank you.
Thank you, Councillor Polly. Councillor Apothecary.
Thank you, Chair, and thank you for the report. I mean, it's a really detailed, obviously really thoroughly researched. I wouldn't expect anything else from Ian, but yeah, it's obviously a really considered report. I have to say, I don't think any of this is particularly new as an idea. You know, I started working in local government in 2008. We were definitely talking about all of these ideas back then. But it is an ambitious thing to do, as sort of Councillor Polly alluded to as well. You know, this is an ambitious set of things to actually try and deliver and achieve. So if that is something that we can move to, that would be a game changer in terms of you know, trying to erase some of those really stubborn health inequalities that are across the borough. My question is a bit specific and a bit technical, but I'm having a little bit of difficulty, and apologies if this is something that other members of the committee are a bit more familiar with, but I've only just joined the committee. But Thurrock Integrated Care Alliance, TICA, could you talk a little bit more about that and about the accountability structures that go along with that? Because I'm just conscious that there is a line in here that says this includes decisions about de-investment and reinvestment, and obviously as local councillors, those are things that people come to us and say, I'm using a service, it's been de-invested, or it's not being continued, or there's a service, they're going to recommission it, but I don't actually like it very much, it doesn't suit my needs. I'm just wondering what the role of local councillors is with TICA, but also those lines of accountability, and that it's not a kind of, oh, well, so there's not a position where the council can say, oh, well, you know, that was decided by TICA, it's up to them what they do. What is that kind of relationship?
Les might need to come in with some of this as well. So TICA is obviously the integrated part of the health and care partnership that sits across our transformation programme and also across our services. And I think in terms of responsibility, they will have the kind of same level of responsibility that the officers currently have, but they will be making decisions in an integrated way. So we've had a better care fund, for example, for a number of years with pooled resource. But actually, if we can use that resource for better decision making, then that's what's going to inform, I think, the decisions on investment and de-investment and where we want to kind of put that money. So, but a lot of that's going to be driven by engagement with communities and actually what we understand are the needs in different communities. But in terms of actually accountability, the same accountability lines to various committees, my understanding is still going to remain. Nothing will change there in terms of those decisions kind of being called into overview and scrutiny, or the role of the Health and Wellbeing Board, or the role of Cabinet. Did you want to add to any of that as well?
Just a couple of points. It's a condition of the new health landscape. So you've got an integrated care board, integrated care system. Each place has to have some kind of partnership agreement that consists of certainly the local authority, health providers, and in the case of Thurrock, much more, our CVS, our community sector, and Health Watch. So that's a committee that is mandated under that new arrangement as they move to a bigger footprint. One of the things I would say, and this is the question about investment and de-investment, is a lot of our strategy hinges on the premise that there is money in the system, but it's invested in the wrong place. So, for example, we see acute hospitals sucking in millions and millions of pounds of resource and doing a very good job. But if we could change some of that to be more preventive in terms of increasing investment in community services that hit people in Kerry's Triangle at the bottom and keep them well. That's a saving to the system because it's very expensive to go to a hospital, but it's also a better use of the money. So it's that kind of freedom that we are looking for as an alliance in Thurrock, to have more control over how we direct the entire, or a large amount of the spend on health and well-being. We believe should be directed by the local people, through their feedback and by members who tell us about the things that people say. So it actually should give greater sort of democratic accountability to the whole process. But as Councillor Polly quite rightly said, and very correctly, this contains an awful lot of moving parts. And one of the reasons, or one of the main things that has to come into place, for want of a better term, to make this really work on the kind of ambitious level that we set it at, is by crafting an agreement between us and the ICS in terms of us having some kind of devolved decision making through the alliance, so not just through the local authority but through the local alliance, and some kind of governance structure going up back to the ICS, because clearly they are the ultimate governance arrangements for South Essex. And that's to be worked out. One of the later chapters that we didn't get to describes how that kind of model of governance and accountability could perhaps work. But it's a big ask, and we're just in that negotiation now.
Thank you. Who are we up to? Councillor Salmons.
I think it's a very good report. You've obviously done lots of work, and I can see why you're doing that sort of work, because, as you say, sometimes by the time people come to you, they're not at this stage, they're at this stage, which then costs more. A lot of people get put off trying to access services because they've got to go this place, that place, this place. And when people are not at their best, it's daunting, isn't it, to go to half a dozen different places just to get something that they should be able to access. So personally, I think it's a very good system. I hope it works for you. The people can just come to you and you can sort of, hang on, you don't just need that, you need this, this, this and this. So hopefully the system should work better if it's carried out right. So good luck with that.
Thank you. Councillor Snell.
I haven't got my own microphone. That's a good place, democratic services. Thank you for your report. And I agree with people on the committee that it's, on paper, a great system. And it seems one of these things that looks blindingly obvious, that if you can get things at a more local level or more personal level, then it should work better. And I agree that it would do. And I am a fan of this. However, there is a however. One thing that does concern me a little bit is that the way things are at the moment is not so much for trying to get things right, it's basically for when it goes wrong. And when it goes wrong, then you can have a look at it and say, well, we did this step, we did this step, we did this step. And you've got a chain of events that should have happened or didn't happen when it goes wrong. My fear a little bit with this is that you're giving the staff the autonomy to make their own decisions with people. Now, that could be, when it goes right, it's fantastic. But my worry is what happens when it goes wrong. Where does the buck start? And what is the upper layer above these people? Because the other thing I'm slightly concerned about, unless it's written wrong in the report, or slightly wrong, is that you're saying you're going to be freed up from the KPIs and bureaucracy. But those are the sort of things that, although the staff might not like that, and even the management might not like that, but we as councillors need to see that, because we need to see that whatever it is we put in place or we agree to be put in place is actually working. So we need to know how do we measure it. But more importantly, what does happen if you've got small teams making their own independent decisions, and it does go wrong, and we all know at some stage it's going to, then what happens then? You said about protecting the staff, and that's good. Obviously, you want it to happen. And don't get me wrong, I do like this, but I'm concerned that when it goes wrong, it just seems that there's a lot of loose parts that could cause us a lot of problems.
Like to respond to?
Yeah, I mean, obviously there are going to be some parameters around kind of, you know, what the learning that happens and kind of and decision making. So kind of we say actually, you know, don't break the law, don't break the bank, keep people safe. So it's not about kind of just saying carte blanche, you know, do what you like. It's within a framework. But actually, we know that actually practitioners or people on the front line are doing things now that aren't the best way of delivering services. And actually, a lot of this is just about actually what changes do we need to make just to actually deliver a better response to people. And for some people, that might be actually, you know, the flexibility to move away from having, you know, a wash every day of the week because that's in their care plan, to actually having a bit of flexibility that allows them to actually do something else with that time that's then facilitated by the person that's kind of providing care to them. And the same with social workers, you know, with our CLS teams, which we put in place in 2018 and initially as a pilot and now all over Thurrock. They've kind of had some really, really successful cases where, because they've had more freedom, and we freed them up from bureaucracy and freed them up from the kind of the decision making that they would have had in place beforehand, and they've been more empowered. They've been able to working in a freer way. They've been able to actually collaborate and actually generate some brilliant solutions for people. So I think we're kind of possibly talking across purposes in terms of the kind of things that staff will be doing. They will be kind of identifying ways of improving what they do, which might be things, you know, how they work closer with other professionals, you know, how they can generate different types of solutions for people. So they're the kind of things that we're talking about to empower them. Or it might be actually, you know, at the moment we might say, well, the eligibility criteria, people have to reach a certain threshold. Actually, they might look at someone and say, actually, if we provide something to them now, even though they don't meet our eligibility criteria, we know it's a cost saving to us and it's better for them because we know that we're going to keep them away from our door. So it's almost kind of giving them the freedom to make that kind of decision as well, rather than actually having to come to Les or to their manager, or actually not do it because actually our policy or our procedure says, no, you have to be eligible, you know, go away and come back when you're kind of in crisis. The issue about performance is quite interesting because I think traditionally, a lot of the ways that we've measured performance have been based on outputs rather than outcomes, and they're not necessarily a great measure of what we're providing to people and whether actually we are providing things for people that deliver better outcomes. So we're not talking about not having measures, but we're talking about making sure that the measures we do have can measure the right things. So it's just having a relook at what we do measure currently, and actually whether they are really telling us what we want to know, and if they're not, what could we do in its place to actually identify whether actually we're achieving success both across the system and for people. So we're not talking about doing away with measurement, but just redefining some of it.
Thank you. I'd like to thank you for the report. It's been, I think it's been about 2 years, so there's a lot of hard work gone on here over the last couple of years. I know that Councillor Ralph has been quite involved in it. I think one of the things that he's pointed out, and I've noticed as well, I think the fact that we've done some quite extensive consultations on it and actually involved Health Watch as well. Who may have brought up some things that possibly that the academics and the officers may not have thought of. So I think it's not quite good. I think it's a very good report. So thank you for that. I'll move on to the recommendations now. So the recommendation is to endorse the Better Care Together Thurrock case for further change, Thurrock Adults Integrated Care Strategy. All those in agreement of endorsing it?
Agreed.
Agreed. Thanks very much. If you wish to depart now, you may. Right, moving on to item 9. The Health and Wellbeing Over and Scrutiny Committee Thurrock Health and Wellbeing Strategy Refresh 2022 to 2026. Can I now ask Joe Broadbent to present the item, please?
Thank you, Chair. In the interest of time, I don't propose to go through the whole paper and the whole document. The appendix to the paper that you've got is the main strategy document that we're asking for comments on today. I will, however, go through a few of the slides just to give an overview to the committee, and also to I'll also just go over a bit of the process that we've gone through to get us to this point. I'd like to start by just, though, acknowledging and thanking all those that have been involved in this process. It's been a real team effort. We've had a core team that have worked on developing this strategy, including Darren Christensen, who's online, and Kerry, who has just presented the last item. We've been working with colleagues across the council and across the Thurrock system. We've worked very closely with Healthwatch and CVS, who led the sort of face-to-face frontline engagement with residents on the strategy, and we absolutely couldn't have got to this point without them. We're very grateful to the help of everyone who's contributed to the process, and particularly those residents, stakeholders and partners who took the time to comment on the strategy as it was in development. We really are very grateful. Just a bit about process. We set up a number of stakeholder working groups at the end of last summer that drafted an initial draft of the contents of the 6 domains of the strategy. We then had the very comprehensive engagement process throughout the autumn and through into December, where we engage with, I think, 1,300 different comments were elicited from various stakeholders as part of that process. We then did a review of all those comments. Healthwatch did a really helpful report on their engagement. Darren Christensen pulled together that with the engagement that myself, Darren and other officers did with professionals and stakeholders. So we went to, I think, every Overview and Scrutiny Committee. We went to political groups. We went to NHS groups. We went to the Disability Forum and spoke to a lot of people. So we have a very comprehensive consultation report that has really informed the final contents of this strategy. And I can give you some examples of that as we go through. So the vision for the strategy is levelling the playing field, which links very much to the national levelling up agenda, but also draws very much on our insight into the inequalities, the enduring and intergenerational inequalities that we see within Thurrock, and aims to take a very broad approach to trying to level the playing field across a wide range of determinants of health. We know that healthy life expectancy varies by 8 years across Thurrock between those living in the most and the least affluent circumstances, and we also know that the playing field is not level across a whole range of issues that contribute to health and wellbeing. And I just wanted to focus on the diagram that's on the slide and that's on in part in the document, because this just illustrates what we know about what influences an individual's health and well-being, and therefore what influences a whole community's health and well-being. The previous strategy focuses very much on clinical care and the quality of that clinical and social care, but it also focuses on some of these health behaviours in the blue circle here, things like smoking, diet and exercise. But taken together, those two things only influence about 50% of our health and wellbeing status. The built environment and the green environment influences around 10% of our status, but the really big one here is these socio-economic factors. This is what really drives an individual's health and well-being. So access to high quality education and educational attainment, access to meaningful employment, the level of income that individuals and families have, community safety and feelings of community safety, and that community resilience in the communities that we live in. These are the really big areas. So this is why we've taken a very broad view in the health and wellbeing strategy to levelling the playing field, because we really need to try and act on all these areas to try and narrow that 8-year life expectancy gap. So I mentioned we have 6 domains. The detail of those domains is in the appendix to the paper. So I won't go through all that detail because it's a huge amount of detail, but just to give you an overview, staying healthier for longer covers the areas that we most traditionally think of in terms of health and well-being, and where a lot of the public health activity under this strategy will sit. So things like helping people stop smoking, reducing levels of overweight and obesity, promoting good mental health, and supporting people who live with chronic long-term physical and mental health conditions. The second domain is building strong and cohesive communities, and this is very much based on the collaborative communities framework and was drafted by the Stronger Together partnership, so very much links into that partnership approach to building community resilience. The third domain, person-led health and care, is essentially where all the detailed work that Kerry and Les were just talking about in the adult health and care strategy sits under that domain. And it's quite helpful that you've had the 2 strategies together, because it illustrates quite nicely how the health and wellbeing strategy by necessity is quite high level and broad, but it is underpinned for every goal that we have with a much more detailed delivery strategy. And so for domain 3, the strategy you've just been discussing is that detailed strategy. So this is how we will be delivering on the range of goals that there are in the health and wellbeing strategy. The fourth domain is opportunity for all. This is a very broad domain that takes a kind of life course approach to opportunity, thinking about early years, the best start in life, educational opportunities for young people, educational and development and training opportunities for adults, and also access to well-paying, meaningful employment. And this is where we get a lot of the links to the backing Thurrock strategy and the Thames Freeport opportunities. Housing and the environment is fairly self-evident what that covers. It covers our housing strategy, the homelessness strategy, and also we're linking with the local plan very carefully in this domain and trying to align some of the levers that we've got to improve health and wellbeing through the built and green environments in the local plan back into the health and wellbeing strategy. And then finally, the 6th domain is around community safety and links very much to the priorities of the community safety partnership. I mentioned both the local plan and backing Thurrock, and this slide just illustrates how these 3 key strategies for the council interact and how we're really trying to generate the synergies between them in the development work that we're doing on all 3 of them at the moment. So they should work together to deliver the council's priorities of people, place and prosperity as illustrated. But the health and wellbeing strategy also is one of the ways we'll be delivering the Mid and South Essex Health and Care Partnership vision, which also focuses on inequalities and actually has 4 priorities that again align really nicely with the people, place and prosperity priorities of the council. This slide just illustrates what I was saying before about how the high level aims in the health and wellbeing strategy are underpinned by these more detailed delivery strategies. The key ones being the adult strategy, but also the brighter future strategy for children plays into the health and wellbeing strategy. And then we've got lots of other strategies such as our whole system obesity strategy, the violence and vulnerability board's work, for example. So this just illustrates how the 6 domains relate to that people, place and prosperity structure. And as you would imagine for the health and wellbeing strategy, most of the domains are aligned to people, but domain 5 is aligned to place and the local plan, and domain 4 to backing Thurrock and opportunity for all. So we should be quite integrated in our strategic ambitions here. And then this is just to illustrate what the detail of each of the domains looks like. I won't go through all of them because you've got them in your pack, but what we've done, so the goals down the left-hand side in bold, these were the things that were drafted by the partnership working groups last year and that we consulted on in the autumn. We then fleshed these out with actions influenced by both our partners' input and the input of residents. So an example, I don't think it's actually on this slide, but an example of where residents' feedback has directly influenced the content of the strategy is around access to information, access to services digitally. So we've added something in around digital inclusion and supporting building digital skills in the population, but also ensuring access to information in a range of formats. That came up very strongly in our consultation. So that's just an example of how feedback from residents has directly influenced the strategy. And then finally, just acknowledgements at where I started, just to say thank you for everyone who's fed in so far and made the strategy as comprehensive as it is. And I will stop there. Thank you. Oh, no, sorry, I won't stop there. One other thing I wanted to say. This is the main strategy document, but we've also got a suite of documents. I've mentioned the consultation report, but we are also producing 3 other, I suppose, versions of the strategy. The first is a partnership version that is a much more detailed version of all this information for each of the domains. I mean, it runs to about 140 pages and it's not, you know, the most user-friendly of documents, but it's very helpful for the professionals working in the system. So we have that level of detail. We're also working on an easy read version that will be published alongside the main strategy documents, and an accessible version that conforms to web accessibility rules, because we thought it was, and we're in relation to the easy read version and the accessible version, we thought with the vision of levelling the playing field, it was very important that we made sure that this work was as accessible to as many people as possible. Thank you, and I will stop there.
Thank you, Jo. Yeah, thanks for your, shall we say, truncated report. But I say we've all seen the documents that's there. I haven't got much to comment on this particular item because I think it's really well presented. I don't intend to necessarily go around the table on this because, unlike when I was chairing full council, I seem to have not run out of time, but overlapped some of the time periods, and I'm conscious of the time myself. So, is there any councillor that has a short statement or a question? Councillor Apothecary.
Thank you, Chair, and thank you, Jo, for the report. I'm actually going to make a really similar, I'm going to ask a question that's quite similar to what I asked you when you came to present this at CGS Overview and Scrutiny Committee, which is around air quality. And for me, there are such pressing issues around air quality in the borough and the link to people's health. And I know it is kind of in here, but the goal does only link to regeneration and future developments. There doesn't seem to be a link through to saying, well, actually, we need to be taking an approach to improving air quality across Thurrock, not just where there might be regeneration going on or redevelopment. So I'm just wondering, how do we pull that in and make sure that that's being put front and centre?
Yeah, thank you. So we do reference it in domain 5, and you're right, it's not referenced in detail. It's worth noting, I think one of the other things that we added in after the consultation period was the link with the climate change strategy and the work going on in the council and the borough around that. That was something else that came up directly from the consultation. So we've strengthened that element of it. What we, as you probably know, we are doing some work in the background to underpin developing a new air quality strategy. We haven't had an air quality monitoring officer for quite some time. I believe someone has now been recruited. So there is a lot of work to do to develop and refresh our air quality strategy. So to some extent, we didn't really want to preempt what was going on in a strategy that hadn't been developed yet. So I think the fact that it's not massively emphasised in this document doesn't mean it's not a priority for us and for the council. I think it's a reflection of where we are in that particular process.
Thank you, Jo.
Anybody else got a question? Councillor Fish.
Yeah, I just wanted to pick up what you said about access to services, in particular access to primary care services. I noticed there's a section on there talking about improved telephony, which I think will be helpful. And in fact, when I visited my GP surgery today, I was given a questionnaire to fill out about what kind of services I think would be better to improve the service. So, for instance, like a system whereby they can ring you back when you're at the front of the queue, that kind of thing. So that's good, but I've recently been using quite a few GP services, and what I found is that several of them are not able to be accessed by me in a wheelchair independently. I can think of one in Tilbury in particular, whereby you open the door, there's a very steep ramp. The ramp is, I've tried to use it, it's impossible to use it independently. And it's because of where it's positioned by the door. There's also like a sort of footwell thing. So you sort of go down before you have to go up the ramp. It makes it really impossible to use it. Coming back down the ramp is actually dangerous because it's so steep that you're going to hit the front door unless you put your brakes on. So how that becomes to be a surgery that's used as part of the hub system, it's used right across the borough by people. I've got no idea. That's, I mean, presumably they said, oh, well, there's a ramp, so it's accessible. But unless we address those kind of issues and make sure all surgeries can be accessed independently by people in my situation, for instance, and everybody else in the community, then the idea of moving services closer to people is just not going to work.
Thank you, Councillor Fish. Any other comments from anybody? No? Lovely. So, well, we'll be required to review and comment on the final draft strategy at Appendix 1. I believe we've done that now. So, thanks very much for your attendance, Joe. I'm sure it was possibly a bit later than you intend to be around. But no, thanks very much for the report, and you can now disappear if you wish to. Well, not disappear literally, but yeah, you can leave the meeting. Thank you.
Thank you very much. You're most welcome.
Moving on to item 10 on the agenda, the work programme. Is everybody happy with the work programme for September?
It's very long, Chair.
What, the work programme? It does.
One for September.
Yeah, it does look rather long, doesn't it?
I can discuss with officers to see if we can. What's on the next? Yeah, see, November's pretty busy as well. So let me speak with officers and see if we can rejig, maybe.
Yeah, it would be. Yeah, I think I'm conscious that.
8 items.
Yeah, and I'm conscious that really items need to be given the amount of time they're required, rather than possibly force the chair to rush through items. So if we can look to see whether some of them can be put back.
You may be able to provide briefing notes on some of the items if it is just for an information.
Yeah, that would be ideal.
With that? Yeah. Okay,
yeah.
Leave that with me, members.
Okay, fine. Thanks very much for that.
Can I request for either an item or possibly a briefing note on a couple of items?
Sure.
We just said that the programme was too long. Yeah,
I know. This is what I'm thinking. Maybe briefing note might be a better idea. But one would be around health and air quality, because I've struggled so much over the last year to get any kind of information from anybody in any kind of position of authority about what we're doing about air quality. So it'd be really good if we could get something pulled together. It doesn't have to be for September, and it could just be a briefing note, but just something pulled together to tell us what the situation is, how it's linking to health, and what the strategy, where we're at, what are we doing. I know. Joe was saying, there's a new air quality monitoring officer coming, new strategy, but it would be nice to know where we are at the moment. That would be really handy.
Yeah. Sorry, go on.
Sorry, and the other issue, I don't know whether you've possibly had a report on this, and apologies that I haven't checked, but you may have had a report earlier in the year on this. But the under-doctoring situation is quite concerning, with the third most under-doctored borough in the country, and that's really concerning. And I know that Tiffany was talking about, you know, there are some GPs possibly in the pipeline, but it would be good to have a briefing on where we are, what's actually happening now, to sort of sort that situation out.
Yeah, I've just looked at the work programme, and I've just noticed that other than Health Watch, there's nothing on January. Are members happy to rather than let's possibly get a briefing note, is to have a report brought forward to us in January?
We might be able to get a briefing note before that.
Or we can get a briefing note and then possibly at that stage decide whether or not we want to add it to the January.
Yeah, that'd be a good idea. Yeah.
Okay, fine.
Super.
So I think Councillor Polly.
Sorry, Councillor.
I was just going to say, with winter pressures and exacerbation of COPDs and chronic lung issues, and that would, if it came to the January work programme on the air quality, that would coincide with, as much as we get trends like for hay fever and summer respiratory illnesses, we also, so if there was a piece of work around the January one, that would probably capture some of the heightened figures around respiratory illnesses.
Yeah, thank Councillor Polly for your expertise, shall we say, in due to the job you do. So yeah, we'll bear that in mind. So anyway, with that, I'm looking for a clock, but someone's going to tell me the time, I'm sure. At 9:10, I thank everybody for their indulgence and call the meeting to a close.